So now we come to that first question. Which patient has better prognosis in breast cancer? Luminal A. What is this luminal A? So cancer breast, we have two pathological exam. One is histopathological examination, that is identifying the, what is histopathology? Identifying the
pathology in the tissues.
Pathology in the tissue. And the same way histoimmunology, that is tissue, will take the tissue, chunk of tissue, and we will discuss about we will study about the molecules, molecular mechanisms. So this is also known as molecular classification. This is also known as molecular classification. Okay, based on the receptors, ER receptor, PR receptor, HER2/neu receptor, we will identify it and we will give a name to it. Okay, so this is based on gene expression profiling. Okay, so it is a very costly affair, also not done in every center. How to do it is, we'll just take the tissue, we'll send it for gene expression profiling, that is they study the genes on the tissue. Okay, so then they will come with this molecular classification. This entire table is not so important for us, but just remember luminal A, luminal B, basal, HER2/neu, and claudin. These are the 5 classifications of molecular type of classification or histoimmunological type of classification. 5 types. Out of these, see here in luminal A, they are ER positive, PR positive, HER2/neu negative. These are all receptors. On the cell, there will be multiple receptors. Estrogen receptor will be there, progesterone receptor will be there, HER2/neu receptor will be there. So ER positive, PR positive, and HER2/neu negative. So it is double positive. We call it as double positive disease. 2 are positives, 1 is negative. It is the most common type. It is having the best prognosis. So this question they have asked you: which patient has best prognosis in breast cancer? So it is luminal A. In the same way, see here luminal B. It is triple positive. All the 3 are positive here. ER positive, PR positive, HER2/neu positive. So it is known as triple positive disease. It has poor prognosis. And basal, it is triple negative, so nothing will work here. It is triple negative, so it has worst prognosis. And these 2 are not so important, but for completion's sake, HER2/neu is seen at younger age. Only HER2/neu positive is seen at younger age. So this slide is little clumsy, but just nothing much to.
Could you show just the previous slide, because I remember there was. Thank you.
This one I'll show it. Yeah. Just you can note it down and you can read it afterwards. There is nothing much to discuss here, but just for luminal A is double positive, ER positive, PR positive, HER2/neu negative. It is double positive. So the 2 points regarding that, it is the most common type of breast cancer and it has the best prognosis of breast cancer. Most common type and best prognosis. Luminal B is triple positive. It has poor prognosis. Basal is triple negative. It has worst prognosis. These 3 I want you to remember: luminal A, luminal B, basal. Basal worst, triple negative. Triple positive is luminal B. Double positive is luminal A. Clear?
Yes, sir.
Yeah. So we'll come to the pathology. The most common gene mutation is P53. The most common gene mutation is BRCA1. BRCA1 is seen on 17q and BRCA2 is seen on 13q. 17 and 13. 17q and 13q. These are the other cancers associated with these 2 things. Male breast cancer also is associated with BRCA2. So chromosome number 17 and chromosome number 13. Remember, yesterday we have discussed chromosome number 3. Today we are discussing 17 and 13. 1 is 17, 2 is 13. Okay. So if these are positive, if a patient has these are positive, then we can reduce the risk reduction strategies. We call it as risk reduction strategies. So what can be done is we can do a bilateral mastectomy. Okay. We can do a bilateral mastectomy. We can remove the tissue so that in future she will not have the chance to develop malignancy. We can do a bilateral salpingo-oophorectomy because ovaries also there is chance of malignancy. And there is a tablet we call tamoxifen. Tamoxifen tab can be given to reduce the risk of breast cancer. So here, for you to remember, one Hollywood celebrity, every time I discuss this, she underwent bilateral mastectomy. Who is that?
Angelina Jolie.
Yeah, she underwent Angelina because she is BRCA positive. Okay, so she underwent bilateral mastectomies. Okay, so this is about the risk reduction strategies. clear till now? So which patient has better prognosis in breast cancer?
Luminal A.
Yeah. Most common histoimmunological type of breast cancer?
Luminal A.
The option, I will change the options: A, B, C, double positive, triple positive, triple negative. Now what is the answer?
Triple
Double
positive.
positive.
Triple positive is the most common. That is luminal A.
No, double positive is luminal
Oh,
A.
sorry. Yeah, double positive.
Yeah,
Yeah,
double
correct.
positive.
Yeah.
Yeah, it is double positive as the luminal A. See here. I told you, right? Double positive. See here. Double positive, most common breast prognosis is luminal A. Okay, don't confuse. Yeah. So now we will move on to the next section. Yeah, early menopause may happen due to premature ovarian failure. Yes. So I told you two types of tissue is there in the breast. One is the duct and one is the granular tissue. In the duct, we have the this is the duct and this is the lobe. Suppose this is the duct, this is the lobe. Concentrate only two things. One is the duct, one is the lobe. And here again in the duct there is in situ cancer, duct in situ cancer, invasive cancer, duct. Lobe also there is in situ cancer and invasive cancer. Clear? Only four things: duct and lobe. Two things: duct and lobe. In duct there is invasive and in situ. In lobe there is invasive and in situ. Yes? No?
Yes, sir.
Okay. So what do you mean by LCIS and DCIS?
Ductal and
Lobar centric in situ.
Yeah.
ductal.
So it has nothing great. It is just lobular cancer in situ. LSCS. DSCS is ductal cancer in situ. Okay. And IDC and ILC is invasive.
Ductal cancer.
Ductal cancer. ILC is
Invasive
lobular cancer. So we have only four. Okay. There is, just remember this: there is a duct and there is a lobe. In the duct there is invasive cancer, in situ cancer. In the lobe there is invasive cancer, in situ cancer. So four. Out of these, the most common is this one: invasive ductal cancer. This is the most common and most malignant also: invasive ductal cancer. Okay. So we'll discuss mainly about invasive ductal cancer, but invasive lobular cancer, only one point regarding this. Sorry for this lettering, it is in yellow. So it is single file pattern. Single file. What is a single file? In army, when they do march pass, they do in 3 files. Okay. But there is a single file, like cells are lined in only single row. Single file pattern. It is bilateral, it is multifocal, and it is multicentric. These are the 4 points which I wanted you to know about invasive lobular cancer. Okay. So it is, first of all, it is single file pattern is seen. Second, it is bilateral. Both the breasts are involved, and it is multifocal and multicentric. What is multifocal?
Many foci.
Yeah, many focal points are there. Multicentric. It is seen in both the breast with in all the quadrants it can appear. Okay, it is multifocal and multicentric. And these are the 4 points: single file, bilateral, multifocal, multicentric. Why this is important is they'll give a big question. So much a 45-year-old patient comes to you with history of breast mass, and on examination there is a proven breast mass, Berat score of 5. You did a biopsy. Biopsy is showing single file pattern. So what is the lesion? That will be the question. So on seeing that single file, you have to be like yesterday manhole. By seeing that manhole, you know that it is a urethral injury.
Straddle.
Sorry. Yeah,
Straddle injury.
Yeah. In the same way, on seeing that single word, you have to pick it up. Single file is there, so you have to pick it up. It is invasive ductal or invasive lobular.
Invasive lobular.
Invasive lobular. Very good. So this is about invasive lobular. Only one, but just very important. Okay. Then invasive ductal we'll discuss. Invasive lobular is our invasive ductal. This has 4 types: tubular, mucinous, medullary, inflammatory. Out of this, inflammatory is having the worst prognosis. This they'll ask you. Which of the breast cancer subtypes of IDC has, infiltrating duct cancer, has very worst prognosis? It is inflammatory. Good prognosis, tubular. Okay. This mucinous is colloid and medullary is BRCA1 positive. Okay. No need to go into that detail, but for understanding sake, infiltrating duct cancer, worst prognosis is inflammatory. Good prognosis is tubular. Which is the most common type of RCC?
Clear cell
Okay.
Sorry?
clear cell carcinoma.
Clear
Is it
cell carcinoma. Okay.
chroma?
So see here, false about lobular carcinoma breast. First answer this question. Answer is already there, but just it presents as a breast mass. Yes, no? Yes, no?
Yes, sir.
Yes. Frequently bilateral? Yes, no?
Yes, sir.
Yes.
And then
Multicentric?
multifocal and multicentric.
Multicentric, yes. So poor prognosis, this is the obviously the answer. Okay. Once you know the other options perfectly, you can go with the answer. It has good prognosis compared to IDC. Okay. So this is the answer. False about lobular carcinoma. See this question. In which of the following types of carcinoma breast, comedo growth pattern? Comedo growth. What is comedo means? It is like toothpaste-like material. Toothpaste-like material. Comedo growth pattern. It is seen. It is seen in DCIS. Ductal carcinoma in situ. Comedo growth pattern is seen. Single file pattern is seen in?
Lobular.
Yeah, lobular.
Invasive lobular.
In situ or invasive?
ILC. Invasive.
Invasive. Comedo growth is seen in?
Ductal.
Ductal. Invasive or in situ?
It's in situ.
In situ.
Situ. Okay, just remember these 2 things. In situ of ductal has comedo growth pattern. Invasive of lobular has single file pattern. Just remember these 2 points. Okay. So can anyone answer this? By now you have to, I think you read breast once. Even for exam sake in the final year you will read, right? So just answer how to answer this type of questions.
D.
Yeah, is it D, sir?
No. Okay.
Stage, it's the second stage because it's 4 centimeters.
Okay.
Then it has gone to lateral mobile. It's mobile LN in excellent staging. So it's mobile. So no metastasis, basically. No. So it's N1 because it's mobile. Yeah, it's N1 and M0, no metastasis. So option A should be there.
Yeah. So tumor, node, and mets. Okay. So we'll see what is that. So T1 less than 2, more than 2 to 5. T2 more than 5 is T3. Right. So it is T2. 4 centimeters I have given. So it is T2. So out of this, T4A, T4B, T4C, and T4D. T4 is again divided into A, B, C, D. A is chest wall. B is skin. C is A plus B. If both chest wall and skin is involved, A plus B. D is inflammatory cancer. So this alone is an MCQ. T4D is inflammatory cancer. And how is the prognosis of inflammatory? Good, bad, worst?
Worst.
It's the worst.
Yeah, it's worst. Okay. So,
Sir, can you show that question again, please?
yeah, 1 minute. Question, na?
Yes, sir, the question. Yes, sir, this one. Thank you, sir. Got it.
So see here, this also you have to remember T4A, T4A and T4B. A is, I just remember by under, A is under, B is bahar. Under means inside. So it is chest wall, inside, chest wall. Bahar is outside, it is the skin. So there is specific, chest wall means these only specific things are there. So what is chest wall? So it is the ribs. So it is serratus anterior, intercostal muscles, serratus anterior, intercostal muscles and ribs. Only these three things. Serratus anterior, intercostal muscles and ribs. Just I'll take a call once. Okay. So it is SIR, sir. That is serratus anterior, intercostals and ribs. These are the three things. Serratus anterior, intercostals and ribs. Okay. So this is about the chest wall. Whereas skin involvement, bahar, it is PUNA, PUNE, pune. It is pudiorange, ulceration, nodule and edema. Only these four things, nothing else. I'll show you the question, then you will answer. See here. In patients with breast cancer, chest wall involvement means involvement of any one of the following structures except. So what is the answer?
The mnemonic sir and then strike of the
yes.
other one.
Yeah, here also, see here. Cancer breast, stage T4B involves all except. Nipple retraction, we have not discussed. Okay. It is pudiorange, ulceration, nodules and edema. Okay. So edema, what is this edema? Dermal edema is nothing but, what is the dermal edema?
Swelling of skin.
Yeah, it is pudiorange. Ulceration, skin ulcer or the swelling. Nodule, satellite nodule. Okay. So nipple retraction is the answer. It is not there. T4B is involvement of, what is that? T4B is involvement of
Bahar, so it's
it's skin.
Skin.
Skin, sorry.
Skin and only four. Pudiorange, ulceration, nodule and edema. So these are the confusing things they will give you. Like dimpling, puckering. We'll think these are also skin findings. No. Dimpling, puckering, nipple retraction. No. And why does this nipple retraction occur?
Due to pulling of the ligament.
Which
It's
ligament or
about
something?
a subareolar duct,
It is due to
retraction of
subareolar
nipple. Yeah.
And dimpling and puckering, why is it due to?
Cooper's
Dimpling and
ligament.
Cooper's ligament, right.
Okay. And pudiorange, why is it due to?
Is subdermal lymphatics.
Very good. So now we have completed T. We'll move on to N. N staging. N1. It is mobile axillary. Axillary lymph node is there. It is mobile. N1.
So sorry, in puny orange, the nipples, don't they look a little retracted?
Where?
Don't they look a little retracted, like a little inverted and not pointing outwards?
It is because of the edema.
In which patient?
Puny orange, sir.
Yeah, nipples will
Okay.
be like it won't be classical retraction like in malignancy. Once you see a malignant retraction, you'll never forget. See, the pull will be there. It will be circumferential retraction. But this edema, there will be just, it will be like a depression only. This nipple retraction will be just like a depression, what you are telling. But once if it is retracted with the, because of infiltration of subaerial duct, it will be circumferentially retracted back.
Okay, sir. Okay. Because I always have difficulty differentiating the images. That's why.
Yeah. So N1, it is mobile axillary lymph node, N1. N2A, there is no like mnemonic or something, we have to mark it up. N2A, again N2 is divided into A and B. A is fixed matted lymph node. N1 is mobile, N2A is fixed and matted. N2B is, suppose this is the breast, this is the axilla, this is the internal mammary. Axillary lymph node is negative, internal mammary is positive. That is N2B. This is negative, this is positive. N2B. N3A is infraclavicular. This is the clavicle here, infraclavicular. N3B is, both are positive. Internal mammary is positive, axillary is positive. N3C is supraclavicular lymph node. Okay. So N1, mobile axillary lymph node. N2A, fixed axillary lymph node. N2B is ipsilateral internal mammary lymph node positive, axillary lymph node negative. N3A is infraclavicular positive. N3B is, both are positive. N3C is supraclavicular positive. Clear?
Yes, sir.
Okay. So here I'll just ask you one question.
Positive indicating the involvement, no, sir.
Yeah, positive means involvement. Yeah, involvement. So a patient has a right breast lesion. Okay. So she has axillary lymph nodes are there, internal mammary lymph nodes are there. Okay. And supraclavicular lymph node is there. Opposite side supraclavicular lymph node also is there. So this is the right side, mass is here. So 1, 2, 3, 4. Opposite side supraclavicular lymph node is there. So what will be the stage?
Can you repeat it once again, sir?
Yeah. A patient is there. She has a breast lesion. Here she has a breast lesion. She has lymph nodes, axillary, mammary, supraclavicular, and opposite side supraclavicular is also there. Not only this side, on the other side also supraclavicular lymph node is there for her.
Is it one of the N3 staging?
So
Yeah.
N3C staging is ipsilateral or bilateral?
Yeah, that's what. It is only ipsilateral. All we are talking is only ipsilateral. These are all ipsilateral only. We are not talking about contralateral things. Okay, just remember this point. So we are all talking about ipsilateral. So
Okay.
once you talk about contralateral, then it becomes M1.
Metastasis.
It has become metastatic. Yes. So see here, if contralateral lymph node is positive, then it is metastatic. This is mind this point. Okay. TNM staging of breast cancer with positive bilateral supraclavicular lymph nodes. With positive bilateral supraclavicular lymph nodes, it is M1. Okay.
Okay, sir.
Yeah. So this is group staging. Once this is done, we'll go here. Group staging. See here. So this is TNM staging. This T, N, and M. This is group staging. And once we will. So this is TNM staging, and once we'll do a group staging. 1, 2A, 3A, 3B, 3BC, and 4. This is group staging. So no need to go into these details, but just for completion's sake, N2 is 3A, N3 is 3C. Just remember these two things. N2 is 3A, N3 is 3C. M1, if any M1 is there, it is stage 4. It has already spread. It is stage 4. Okay. Yes, no?
Yes, sir.
Yeah. So where are we? We have talked about TNM staging is over. So now we will talk about group staging. So this group staging is primarily derived to stage into diseases like yesterday I was talking about prostate cancer, localized, locally advanced, and spread metastatic. In the same way, early breast cancer, locally advanced breast cancer, metastatic breast cancer. There are 3 types: early, locally advanced, metastatic. So metastatic is simple, M1. One lesion outside, metastatic is M1. It is stage 4. One lesion elsewhere is stage 4. Okay. Yeah, everybody is there. I can see 33. Following?
Yes, sir, following.
Yeah. So early lesion. What is this early breast cancer? It is stage 1, 2A, 2B. That is, see here, T1N0, T2N0, T3N0, and T2N1. That is with single mobile axial lymph node and up to 5 centimeters. Single mobile axial lymph node up to 5 centimeters. That is early. Whatever in between is there, it is locally advanced. So this no need to mug it up completely. So just remember, lesion with mobile axial lymph node, that is early. Any other finding like supraclavicular lymph node, infraclavicular lymph node, any other finding is locally advanced. Metastatic is metastatic. That is metastatic breast cancer, M1. That is stage 4. Okay, we can classify it accordingly. So treatment aspects differs because of based on these findings.